So, good evening, friends. This is Dr. Balasubramanian from ADrPlexus. Let us start with our NEET recall session for biochemistry, and hope you all have done your exams well. And this is a pretty straightforward and it's a pretty easy paper. So to begin with, I must say that the scope for margin of error has been tremendously low in this paper. Okay, so we cannot afford to lose any questions via careless mistakes, because everything is from the book, straightforward. There is nothing that is even that they haven't even touched any genomic hard topics. They haven't even touched or went beyond for any advanced topics. Everything is as per the book. Okay, so I hope all of you have done well and made justice to your preparations. And always the exams are over, so we are having our preparations. We have done the exams to the maximum best of our capacity. Rest is left to God. Okay, so let's all hope that you all crack the exams very nicely and get the seats of your choice. So let us start the session with our recall of all the biochemistry questions that has been asked in your NEET 2021 exam. So here, let us. There is approximately 12 to 13 questions that has been asked in the biochemistry examination in this NEET 2021 PG. Okay, so in these 12 to 13 questions, what has happened is we are all asking the students for the options. Okay, so some of the options are jumbled, some of the options are not recalled properly by the students, but almost 90 to 95% accuracy has been maintained in this discussion. We have got all the questions and all the options via wide feedbacks across the state and country from all the students who have appeared in it. And so supposedly some of the options may be more or less close, so kindly bear with that for that. Okay, and to start with, last week and the week before, okay, just in a span of 7 to 10 days, I have done 2 videos. Okay, each video comprising of 10 plus 10, 20 questions. Okay, towards the preparation of last minute rapid review revision for our ADrPlexus. So from these 2 videos alone, 2 questions have come for this examination. You just spend 2 hours, it could have got you 2 questions right in biochemistry, and 2 questions is a big way. It can change someone's fate from pediatrics to ENT or orthopedics and radiology. Everything depends or hangs on these 2 questions. So that is the importance, the level of importance you have to gather and assimilate information wherever it is available. Okay, so one question was on DNA repair, the other question was on familial hypercholesterolemia. So both we will discuss as we go through. So this is our discussion videos I have shown. Okay, let us start with question number 1. I have arranged the questions in the order of chapters as per Harper. I have given all the references from Harper. Everything is from the textbook. So I hope you will find all the content in your textbook. I have mentioned the page numbers also for your reference, right? Okay, in a student experiment on electron transport chain in a medium containing pyruvate, ADP and PI, phosphate inorganic, ATP was getting produced. Later, a compound was added and then the oxidative phosphorylation decreased. What is that compound? Okay, so it's a very, very straightforward and simple question. See, there are 2 components here. One is oxidation, the other one is phosphorylation. Okay, so predominantly the question was focused around the ATP synthesis. So there was ATP synthesis which was going on, but then finally some compound was added and then the ATP synthesis started to decrease. So there is some inhibitor which has been added that has stopped the ATP synthesis. Very simple, very, very simple. So we just need to know the compound which will stop the ATP synthesis, right? So before going that, let us see the options. Oligomycin, 2,4-dinitrophenol, antimycin, rotenone. See, these are the 4 options. Okay, let us briefly look at the electron transport chain. This is in Harper, page 322. All right, bioenergetics chapter. Okay, so there are 4 complexes. Complex 1, complex 2. In between, there is something called as a CoQ. Okay, and then there is complex 3, and then there is complex 4. And some people say there is another complex called as complex 5, which is called as ATP synthase enzyme complex. ATP synthase enzyme complex. Okay, so this is the complex where there is the ADP is converted into ATP. ADP is converted into ATP, right? So here specific in here, I'm not going into the details. Okay, so each complex is pumping 4 protons. So complex 2 alone doesn't pump protons. So 4 protons from complex 1, 4 from complex 3, and 2 plus 2 protons from complex 4. So total amount of 10 protons pumped into the other side of the membrane, and then through the ATP synthase pump, it is all the protons are coming through the protons, the gradient, and then the protons are coming through this pump. While they are coming through this pump is rotating and it is going to generate ADPs. With that electromotive, with that kinetic energy, the ADPs are phosphorylated into ATP. This is the concept behind electron transport chain. But then the question focuses on inhibitors. So selectively we will see complex 1 is there. Complex 1 inhibitors are tyrosine, amobarbital, rotenone. Complex 2 inhibitor is malonate. Not only malonate, your book also mentions carboxyl and TTFA. Okay, complex 3 inhibitor, yeah, it's there, complex carboxyl and TTFA. Complex 3 inhibitors, BAL and British anti-lewisite. It was a drug which was discovered during World War I. Okay, British anti-lewisite, antimycin A and rotenone. All right, so BAL, antimycin A and rotenone. All these are here with complex 3. Okay, and complex 4 is very classic, our cyanide and hydrogen sulfide, carbon tetrachloride. All these things are complex 4 inhibitors. So all of you have already a knowledge about all these inhibitors. Is a very straightforward question. Okay, so none of these complexes are directly concerned with the inhibition of ATP synthesis. Okay, there has to be some compound which will inhibit this enzyme in order to stop the conversion of ADP plus PI into ATP. That compound is called as oligomycin, which is a ATP synthase inhibitor. Okay, there is another compound called as atractyloside. This compound is the one which shunts the ADP from the cytoplasm into mitochondria. So this is a transporter. So if this is not there, also ATP synthesis will come, but then that is not given in the option. Okay, you got only oligomycin. Then what about, there is another one option, the other two options. So this is right. This is complex 3, complex 3. All right, fine. This is this both we have. I have got you. Okay. What about this option? This is an uncoupler. Uncoupler means, see, the whole electron transport chain based on the movement of electrons from the most electronegative and more electron positive to the electronegative. Oxygen is the more electronegative, right? So the electrons are shunted here. When the electrons are shunted, protons are going up. Then protons are creating electromotive force gradient, and through the ATP synthase, it is coming down inside, right? So this potential difference between this end to that end is what is driving the electron transport chain. Sometimes what happens is there is a substance which causes the electron transport to dissociate from the generation of ATP synthesis. So two movements are there. One is electron transport. The other one is ATP synthesis. Okay, both must simultaneously go. That's why it is oxidative phosphorylation. This is called as oxidation. This is called as phosphorylation. But uncouplers are substances which will uncouple, which will separate these two processes. Only the electron transport will happen, but then the oxidative phosphorylation, all the energy is dissipated as heat, right? Okay, so all these things, this can also be happening. Okay, but here it is not, uncoupler is not a role to play here. Okay, only the both the, so it's oxidative phosphorylation. So they have not given the separately, they have given oxidative phosphorylation as a together, it has decreased, which means ATP synthesis has decreased. Means it is not completely stopped, it has decreased. So uncoupler is not an option here. So oligomycin will be the right option as far as this question is concerned. Very simple and straightforward question. A person has a dinner at night 8 p.m. and records fasting blood glucose at 7 a.m. Okay, some people say the value was given 180 milligram per deciliter. Some people say it's no value was not given, it was just high. But then the whole question is depending on the time duration, right? It's 8 p.m. to 7 a.m. approximately 11 hours. Somebody would have told you 10 to 12 hours is called as fasting. Okay, now everybody knows that what is the source of this glucose? It's not obviously dietary glucose. Very easy option to rule out. Okay, it's not obviously muscle glycogenolysis. Only option confusing is Hepatic gluconeogenesis, whether it is gluconeogenesis or it is glycogenolysis. In order to answer this question, you must understand the metabolism responses in cases of fasting and starvation. This diagram given in Harper page 357 will give you all the details you need to know. See, this is hours of starvation from 0 to 12 hours. This is the starting of starvation. Until then, this is called as fasting, right? 10 to 12 hours as fasting. So with this, you all know that everybody takes food, then the sugar level spikes, then the insulin is secreted. Okay, throughout the period of fasting, the insulin is working, and during the fasting culmination, what happens is, look at here, the insulin concentration keeps on coming down, the green line, follow it. Okay, towards the culmination of fasting, it's completely calm, and the glucagon concentration attains the peak. Now glucagon stimulation will only result in the gluconeogenesis. So in order for gluconeogenesis to kick in, you need to complete 12 to 24 hours of fasting, right? So until that phase, what is the basic source of energy for our body in order to sustain the blood glucose that is needed for resting and for needed for brain and for needed for basic metabolism, basal metabolism? You can see the glucose level. See here, it is keep on dipping. At this particular level, it will start to spike again. That is because the insulin wanes and the glucagon takes over. So what happens is, hepatic glycogen stores are tapped into first. The first thing to respond will be the hepatic glycogen stores. So until the period of 11 to 12 hours, right, the glycogen is going to get breakdown and it is going to supply all the glucose you need. Once the 12 hours is crossed, the glucagon action is going to kick in and the glucose will start to be produced from other substances. What are the other substances? Propionate, acetyl-CoA, glycerol, lactate. These are the 4 substrates for gluconeogenesis. So all these 4 substrates are going to kick in and it's going to start the gluconeogenesis. So very, superficially easier question, but a little bit tricky concept. Only if you know this particular graph, then you will be able to answer this question. The answer will be hepatic glycogenolysis. That's the answer for this question, right? Question number 3. Here, see, again, there is confusion in the options of these questions. Okay, but then the concept is very relatively simple. Okay, somebody says there is pyruvate. Okay, the pyruvate is converted into acetyl-CoA, and acetyl-CoA has a lot of fates. Acetyl-CoA can get converted into 4 different fates are there. Again, acetyl-CoA, right? So acetyl-CoA has a lot of fates, and this pyruvate is getting converted to acetyl-CoA by a particular enzyme complex. What are the enzymes which are involved in this process? That is exactly what the question is. Okay, so even before going into the options, let me clarify. The pyruvate to acetyl-CoA conversion is done by a complex called as PDH complex, pyruvate dehydrogenase complex. It is a complex with 3 components. 3 components. Goes by E1, E2 and E3. Okay, this is the component E1, E2 and E3. Wait, what is basically happening here? See, pyruvate is a 3-carbon compound. Carbon 1, carbon 2, carbon 3. 3-carbon compound. Okay. Now, what is happening in the first step is this pyruvate is getting dehydrogenated. The pyruvate is getting, what is dehydrogenation? Removal of hydrogen. It's getting dehydrogenated and it is converted, removal of 1 carbon dioxide, and it's getting converted into thiamine diphosphate. So, what is happening here is there is a transfer of hydroxyethyl group. Hydroxyethyl group, and this uses thiamine or vitamin B1. So vitamin B1 or thiamine in the active form, thiamine pyrophosphate. This is the first step. So the first step uses an enzyme called as pyruvate dehydrogenase as such. Okay, pyruvate dehydrogenase. Step 1. The second one, this is a complex. This is the first enzyme is pyruvate dehydrogenase, and the complex is called as pyruvate dehydrogenase complex. The second step, dihydrolipoyl transacetylase. See, what is happening is this is transfer of acetyl group. That's a transfer of acetyl group. Okay, so dihydrolipoyl transacetylase. In order for this to occur, we need another factor which is called as lipoic acid. We need another factor called as lipoic acid. Okay, so now what is happening is we get a compound called as lipoamide. and to it acetyl group is added, which is acetyl lipoamide. So thiamine pyrophosphate, we get hydroxyethyl dithiamine phosphate, to which lipoic acid is added, lipoamide, to which acetyl group is added, acetyl lipoamide. Now to this acetyl lipoamide, we need to put FAD, we use FAD and NAD, got converted to FADH2 and 2NADH, and then we add another. So this, again, some people say this comes from vitamin B2, this comes from vitamin B3, okay, and then finally we add a molecule of CoA, which comes from pantothenic acid, B5. So 5 different components are used, of which vitamin B1 is used, lipoic acid is used, riboflavin is used, niacin is used, and B5 pantothenic acid is used in form of CoA, thereby converting the pyruvate to acetyl CoA. The last enzyme which uses the FADH2, NADH2, FAD conversion and NAD to NADH to NADH conversion is a dehydrogenase. Obviously, it is a dehydrogenase which acts on the acetyl lipoamide. So it is dihydrolipoyl dehydrogenase. So there are 3 enzymes. One is pyruvate dehydrogenase. Second one is dihydrolipoyl transacetylase. Third one is dihydrolipoyl dehydrogenase. Now, predominantly they were asking which is E1, E2 and E3, or they were asking only E1 and E2. So if you know the answer, then you will get the options right. You read somewhere saying that pyruvate decarboxylase, pyruvate oxalase was there. Wrong. Okay. Now the sequence again, E1, E2, E3, again wrong. This is the only option which is right. Pyruvate dehydrogenase, dihydrolipoyl transacetylase, dihydrolipoyl dehydrogenase. So question number 3 is solved, right? Okay. Now question number 4. A 5-year-old patient presented with anemia, bone pain, hepatosplenomegaly. The refined biopsy of the bone marrow taken and the result shown is here. What is an enzyme defect? Very classic picture. This looks like a crumpled paper. Right, this looks like a crumpled paper. Crumpled paper appearance is seen in one particular type of cells, Gaucher cells. Say histocytes, they are basically histocytes. So this, they have just given you Gaucher cells, they are asking the enzyme defect, right? This is all part of the lipidosis, lipid accumulation disorders. Okay, so all this is coming under lipid accumulation disorders. So the whole tabular column is given in your Harper, page number 578. You can just go ahead and see that. Okay, out of this, Gaucher's is the most important disorder because number 1, Gaucher's does not have cherry red spot. And when there is no cherry red spot, there is no mental retardation, even though Harper might say that in infants there might be mental retardation. Okay. But there is basically, we don't classically see that mental retardation, but rather there is erosion of long bones, which is seen in the Gaucher's disease. Erosion of long bones is a very classic picture. That's why this guy is having bone problems. That's why they have taken bone marrow biopsy, refined biopsy of the bone marrow. Okay, and then there is bone marrow suppression. That's why he's landing up with anemia, and of course all the storage disorders are going to result in hepatosplenomegaly. All right. So what is the enzyme defect here? Gaucher's is caused by an enzyme called as glucocerebrosidase, or some people call that as beta glucosidase. Beta glucosidase, right? Here it is, beta glucosidase, right? You see, in this tabular column, there are certain particular things which I need you to remember. See, when we take class, I will show the whole picture where GM3 is there, GM2 is there, then ceramide is getting converted because of Arbus ceramidase deficiency is there, sphingomyelin is there, sphingosine is there, everything is there. We can show the picture. But for an exam point of view, I want you to understand that the enzymes are at least most important. Tay-Sachs is because of hexosaminidase A. Fabry, A is there. Fabry, alpha galactosidase, you can remember like this. There is the beta galactosidase which will come in Krabby. So you should remember after F, K comes. So alpha and then beta, like that you can remember. F is for alpha, K is for beta, all right? In the same alphabetical order. You just have to remember that Fabry and Krabby both are with the same galactosidase, but then which is alpha and which is beta, you have to remember, right? Metachromatic leukodystrophy, again it's a sulfatide based disorder, okay, sulfate lipids, okay. So it's aryl sulfatase is the enzyme which is going to go there, and characteristic demyelination findings in the MRI brain you will have in metachromatic leukodystrophy. Of course, metachromatic granules are also seen there. Gauchers I have shown you. Niemann-Pick, again mental retardation is there. Sphingomyelinatus, most of you will answer Niemann-Pick is sphingomyelinatus. Everybody knows that, right? Faber is ceramidase. It's very easy, right? Don't worry about the lipid accumulating, at least the enzyme part. In Fabry, there is angiokeratoma, right? It affects the blood vessels, it affects the skin also. Okay, if you want to see classic Fabry's presentation, you can watch Dr. House, Google Dr. House Fabry's, you will get the season number and episode number. You can watch all the presentations of Fabry's disease if you are at large here, right? So in Gauchers, this is a classic picture, and Gauchers, you will have certain enzymes elevated, angiotensin converting enzyme, chitotriosidase. These are markers, right? So all these things, trapped enzyme, and of course enzyme something. Most of the enzymes are all these enzymes are very much increased in Gaucher's disease. Okay, so Gaucher's is one of the very important disorders as far as lipid storage disorders are concerned. Please pay attention and please have this tabular column at the back of your hand and mind. Right. A patient with tendon xanthoma, high LDL and high serum cholesterol. What is the diagnosis? Very clearly I have explained last time. Very clearly I have explained. Okay, so let me construct the tabular column for you again. Somebody has missed. Okay, so there are how much disorders? Okay, type 1, type 2A, type 2B, type 3, type 4, type 5, right? Type 5. Type 5 is nothing but type 1 plus 4. You can easily remember. Okay, so what you have to remember, what is the defect, what is the accumulation of lipid, whatever lipid is accumulated. Finally, any characteristic clinical picture. Okay. So type 1, the defect is LPL, lipoprotein lipase defect. Okay. Type 2A, it is LDL receptor. Then type 2B, it is ApoB defect, right? Type 3, it is ApoE. ApoE is the lipoprotein ligand for remnants. Okay, so all this is going to get accumulated is remnants, right? Type 4 is triglyceride metabolism defect. As I said, type 5 is type 1 and type 4 together, whatever it is. Again, it is endogenous. Now, in lipoprotein lipase defect, the accumulation is chylomicron. Here it is LDL. I will write down the basic things. Okay, here it is remnants, chylomicron remnant, all the other remnants, or somebody even say that it is IDL, right? And then here it is type 4, it is triglyceride. Type 5, chylo plus triglyceride. So chylomicron is always called as exogenous lipid and triglyceride is called as endogenous lipid. Okay, so type 1 is called as exogenous hyperlipidemia. Type 4 is called as endogenous hyperlipidemia. Type 5 is called as familial combined hyperlipidemia or mixed hyperlipidemia. Type 2A is called as familial hypercholesterolemia. Now this is the classic picture. LDL cholesterol is accumulated and hence total cholesterol is accumulated and hence it is causing atherosclerosis, which results in heart problems. Sometimes pancreatitis also can be seen, and this particular cholesterol will get deposited in the tendons, leading to something called as xanthomas. Tendon xanthomas, very classically under Achilles heel, Achilles tendon. So tendon xanthomas are seen. Now it is very clear. Okay, high LDL, high serum cholesterol, tendon xanthoma. Everything is pointing towards only one thing, type 2 or familial hypercholesterolemia. Lipoprotein is type 1. Sorry, type 1, and this is also type 1. hyperchylomicronemia. What about Tangiers disease? Tangiers is not in this spectrum. It is not in a hyperlipoproteinemic spectrum. It's rather in a hypolipoproteinemic, concerned with HDL or alpha lipoprotein disorder, Tangiers disease. Defective mean less HDL. That's the problem in Tangiers. Okay, fine. Tangier is the capital of Morocco. Okay, which of the following amino acid to be supplied in the diet of patients with cystathionine beta synthase defect? This is first I took bioenergetics. From there I have come to slowly carbohydrates. From there I came to lipids. Now I have come to protein. Same order as in Harper. The questions also I have arranged, right? So what are the options? Cysteine, methionine, serine, homocysteine. See, people, it's a very easy question, but people get confused. So many of students are asking me, why can't be this? Why can't be that? Always remember, A plus B gives rise to C. Some defect is there in the middle of this. Then the person will have accumulation of A plus B or deficiency of C. It is very simple. Now there is a problem. The enzyme is problem. That person needs something. Which one you should supplement? You should supplement C. Am I right? That is going to be deficient. See, there is a tap. The tap is blocked. So the water will come where? Water will come until the block. After the block, there will not be water. At the output will be nothing. You will not have water in your hand. Like that. Here, the deficiency part only you have to supplement. So the reaction you understand, homocysteine plus serine homocysteine plus serine is acted upon by an enzyme called as cystathionine synthase. This is the enzyme cystathionine synthase. It will give rise to cystathionine, right? Now cystathionine is be broken down by an enzyme called as cystathioninase. The enzyme which breaks down cystathioninase into cysteine and homoserine. Now they have classically asked if this enzyme is problem. A plus B equal to C. Now supposedly supposedly cystathionine synthase is defect na, this will not be produced. If this is not produced, this is not produced, this is not produced, right? So which one you should supplement? You should supplement either cystathionine, which will be broken down, or you should supplement cysteine or homoserine. Now look at the option: cysteine, methionine, serine, homocysteine. Which one you will supplement? People are asking, why can't it be serine? Why can't it be homocysteine? How we can supplement serine or homocysteine? You can't supplement serine or homocysteine because it will lead to further accumulation. You have to supplement only the cysteine. Cysteine is the part which is going to be particle which is going to be deficient. So obviously you have to go ahead and substitute cysteine, right? Right. A patient presented knee pain and other routine examinations being normal. Other routine examinations are normal, but he has only knee pain, right? Urine blackening on exposure to air. All this is very classic. Urine blackening on exposure to air. What's the enzyme defect? Everybody knows this one is alkaptonuria. Everybody knows. And everybody knows alkaptonuria, the enzyme defect is homogenetic oxidase. What is there to explain? So everybody knows that. So all this you know, ochronosis, pigment deposition, all the blackish discoloration of the ears, cartilageous accumulation, intervertebral disc accumulation, everything people know, right? Alkaptone bodies, those are the particles which are causing the pathology in this case. Okay, but anyways, I will just revise the entire phenylalanine tyrosine pathway for your benefit, right? So phenylalanine is there. Phenylalanine is acted by an enzyme called as phenylalanine hydroxylase. The defect here, if this enzyme is gone, is PKU, right? PKU or phenylketonuria. So phenylalanine is converted into tyrosine. Tyrosine has two phases that I will deal later. Tyrosine transaminase. If this enzyme is gone on a defect, then it will lead to something called as tyrosinemia type 2. Some people call this as Richner-Hanhart syndrome. There is another issue here. Complete deficiency of this type, this TAT enzyme is Richner-Hanhart syndrome. Partial deficiency will lead to another disorder called as Hawkinsinuria, which will lead to tomcat urine order. Okay, like Harkinson urea. This defect is called as Harkinson urea, right? So tyrosine is converted into hydroxyphenyl pyruvic acid. This enzyme we haven't labeled, but this is para-hydroxyphenyl pyruvate dehydrogenase. Okay, so if this enzyme converts the hydroxyphenyl pyruvic acid into homogenesic acid, correct? Okay, so if this is gone, then it is tyrosinemia type 3. Is type 3. Good. Homogenesic acid is converted by homogenetic oxidase. You all know that. If this is gone, then it is alkaptonemia. Here is the question. This is the question. It's going to mallyl acetoacetate, then mallyl 2 isomer is there, fumaryl acetoacetate. Fumaryl acetoacetate hydrolase is the enzyme. If that is going to be affected, then it will lead to something called as tyrosinemia type 1. Some people call that as oculocutaneous tyrosinemia, oculocutaneous, albinism will be all those. Right. Now, coming to these two fates of tyrosine. Tyrosine is acted upon by an enzyme called as tyrosine hydroxylase. It gets converted into DOPA. DOPA will get converted to dopamine, norepinephrine, and epinephrine. Now, this enzyme is affected means it will lead to decreased catecholamine synthesis. That's another MCQ. Catecholamine synthesis. This is fate number 1. Fate number 2. Tyrosine is acted by an enzyme called as tyrosinase to convert it into DOPA. Tyrosine hydroxylase also gives DOPA. Tyrosinase also gives DOPA. Okay. So this DOPA will lead to dopapinone and finally melanin. Okay. So DOPA, dopapinone, melanin. Right. So if this problem tyrosinase is affected, then this melanin will be decreased, and melanin decrease will lead to a disease called as albinism. Right? So this is the basic cruxes of this very hyper important phenylalanine tyrosine metabolism pathway. Everybody should know this pathway. Like it's very easy. There's nothing to even mock up. You just have to know the names of the enzymes and the disorders which are associated with that. Right? Okay, mismatch repair defect is seen in very classic, very clean, and it's given in Harper. Everything is given in Harper, and I have discussed this question in my video. And so everything is clear. Okay, so what are the 4 basic causes for DNA damage? Okay, what are it's maybe a single base disorder. Single base may be disorder. More than one base, maybe classically 2 bases may be a damage. In chain break or strand break. Then it is 2 strands, both the strands, cross-link problem. Cross-link issues. These are the 4 different type of damages that can occur to DNA, and all the things which can cause mutagens, chemicals, physical agents, biological agents, chemical agents, radiations. All these things can genetic environment. All these things can cause all this any of the damages. Ultraviolet light. So any of the damages that can be achieved. So it's totally divided into 2 types. One is single strand disorders, double strand. In single strand, again 4 different types are there. Okay, number 1, mismatch. Number 2, base excision. Number 3, nucleotide excision. Number 4, direct repair. Homologous end joining disorders, non-homologous end joining disorders. Homologous means same, repair. Non-homologous means cross-link. This is the problem. Like this. Okay, so all this is given in your Harper. Just get the names. Page number 902 will give you the details of what are the diseases, which is this is an AIMS question. Non-homologous SCID, already asked in the AIMS exam. And homologous repair, mainly I would say focus on Bloom syndrome. Bloom's is very classic homo, and BRCA genes, BRCA1 and BRCA2. And nucleotide excision repair, everybody knows. Xeroderma pigmentosum, and then cocaine syndrome. All these are nucleotide. That is because of classic ultraviolet light induced thymine dimer combination, right? Okay, and then base excision repair, base extinction repair, there is something called as polyposis. That is also a polyposis that is called as mute Y or H, associated polyposis. Whereas the question H and PCC are, some people prefer to call this as Lynch syndrome, is because of defective DNA mismatch repair. Nothing to worry in mismatch repair. See here, see C, it is G. Okay, the pairing has to be complementary. C has to pair with G, G has to pair with C. Supposedly there comes another pair. Okay, this is the defective pair. Okay, so what will happen is that particular portion will be removed by a something called as GATC endonuclease. That's an enzyme which is removing it. And then DNA polymerase will come and it will correctly rearrange the sequence. And then there is something called as DNA ligase, which will come and put the gum and seal the strand. So this is called as mismatch repair. There's a problem in mismatch repair. It's going to land up with defective, a lot of polyps in the coli. That's called as HNPCC. All right. What is the diagnosis based on this dermatologic findings in a child with white or spots? Dry eye is very clean. Vitamin A deficiency. And vitamin A deficiency, which is a dermatologic manifestation, is it rhinoderma, rictiosis, or follicular eczema, or keratosis pilaris rubra? Everybody knows rhinoderma or toad skin. It is a toad skin. Why? You have to know the functions of vitamin A. It exists in three forms, right? Retinol, and then retinoic acid. That's a palmitate, all this. Okay. What are the functions? Genetic, gene expression, then for bone, then for visual cycle, then for decreases inflammation. It decreases inflammation. Sometimes it's called as anti-infective vitamin. Okay, and then obviously the last one is skin, epithelium. It says the integrity of the epithelium. Okay, so this is the problem. If vitamin A is going down, then the skin will show manifestations because of the defective epithelial integration. What will happen is that the skin will have some lesions that will make the skin looks like the frog skin. Okay, see, when some people say vitamin A is with the reproduction also. All these are functions of vitamin A. Okay, so here basically the skin is differentiation of cells. That's a problem here. Differentiation of the cells is basically cut off by vitamin A deficiency. All the other things about vitamin A deficiency, how much is the biological requirement, 750 to 1000 corresponding units, all those things you will be knowing that. Okay, so I'm not going into much details. The night blindness, bite out spots, all that fundus grading and gradings of the eye, XA, XF, everything you will know. So all this is basic concepts about vitamin A. Okay, now one comment I saw during the discussion, one of the students said, God is great just because in NEET he gave 2 questions about pellagra out of the 200 questions. 1% of your exam has been made easy because of the pellagra, right? 1% of 200 is 2 questions, correct? So 2 questions came from pellagra. God just gave 1% just like that he has mentioned. So whatever it is, the questions were not recalled properly, but this is the core recall of what students have told me. An alcoholic patient with history of symptoms suggestive of pellagra, clinical history, symptoms suggestive. What history is to be asked from this patient? So before we go into the options, the clinical history of pellagra is basically diarrhea, dementia, dermatitis. If pellagra is not treated within 4 to 5 years, it will lead to death. 4 days, correct? Some people used to ask me, sir, why the pellagra is manifesting itself as skin lesions, right? Skin lesions of dermatitis, that is because the niacin is overly efficient in the cells that have a rapid turnover. Okay, so these skin cells are the ones which have a rapid turnover. They keep on producing, destroyed, everything. So classically it will be mentioned, manifesting even before the other symptoms appear. The skin symptoms will become very classic in pellagra. Usually there will be in follicles, there will be eruptions and skin lesions and something called as Casel's necklace, a blackish discoloration around the neck also. I can show that picture also. So all this thing is there. Now diarrhea and dementia, obviously you all know about the symptoms and why the reason is that is because of the pathway. Okay, so what is the pathway? The whole crux is involved in an amino acid called as tryptophan. 60 milligram of tryptophan gives rise to 1 milligram of niacin. That's the ratio. That's another MCQ. How is this tryptophan getting converted? Tryptophan is getting converted to N-formyl kynurenine. And then from there it is coming to kynurenine. This kynurenine will give rise to antranilic acid. Antranilic acid and then hydroxyantranilic. Okay, from there it is having two pathways. Okay, one is a quinolinate pathway, other one is a kynureninase pathway, right? So it can go ahead and produce the niacin. One is a pathway which is producing the niacin. The other one is a pathway which produces acetyl-CoA. So we are bothered about this one. We are bothered about this one. See here, hydroxyantranilic acid. It will give rise to quinolinic acid. Quinolinic acid is converted to niacin, and niacin is converted to NMN. So QPRTase is an enzyme. QPRTase is an enzyme which gives rise to NMN and NAD. These are, that's why people say NMN and NAD all come from niacin, vitamin B3 oriented. That is because of the sink in these pathways, right? But one thing you should understand is this kynureninase is a very crucial enzyme. Why crucial enzymes? This kynureninase is inhibited by estrogen, which means females have a naturally ongoing inhibition of kynureninase, and hence the pathway which is synthesizes niacin. That is why pellagra manifests in a ratio of 6:1 when it comes to women to males. Okay, nobody would have told you this, but this is the fact. If 7 people are affected, 6 would be females in pellagra. Very common in females. That's because of this kynureninase problem, right? Pellagra is divided into two types. One is called as primary pellagra, and the second one is called as secondary pellagra. Primary pellagra is very easy to treat. That is because there is a problem in the diet. If there is a deficiency of intake of tryptophan, if you correct the tryptophan deficiency, then or niacin deficiency, then you will get rid of primary pellagra. Secondary pellagra is a different issue altogether. There is a problem in the transport, there is a problem in the metabolism, there is some disorder per se which is not affecting the niacin to be synthesized properly or to be utilized properly. That is called as secondary pellagra. Okay, so now, sir, primary pellagra is the most easy to treat. You said, what are the diets which will cause pellagra or which will cause niacin deficiency? There are 3 things. Okay, so corn based diet, maize based diet. Okay, corn and maize based, and then sorghum or jowar. See, maize is in America, Central American and Mexico, and Honduras, Mexico. Sorghum is Central and Western India, Madhya Pradesh, Maharashtra, Northern Karnataka, this belt. Sorghum or jowar mainly. Okay, so here what is happening is either the niacin is not available or it's a niacitin. In corn, niacin will be available in the form of niacitin, which is not conducible for our body. Our body cannot utilize this. Or this maize will contain something called as a leucine. Leucine content is more. Leucine will inhibit the niacin tryptophan conversion to niacin. So all these things are against our body to synthesize niacin from tryptophan, and hence it will lead to pellagra, right? Okay, so here classic picture. So again the question is, in a patient on maize diet, they have asked maize diet with diarrhea, dementia and dermatitis. So sorry, so what is the history you should have? History should be diet, neurological manifestation for diarrhea, skin lesions. All this is there, then that option is going to be correct, right? So in a patient on maize diet with diarrhea, dementia, dermatitis, which vitamin is very classic. See his hands, see his legs, see his neck and see his lips, all these things. Pellagra, niacin is the answer. Very straightforward. Transparency of corneal endothelium is maintained by, if you go ahead and take Harper page number 1473, the same word is given. Keratin sulfate maintains the transparency of corneal endothelium. It is given straightforward. Straightforward, they have picked it up. But then you have to know this mucopolysaccharidoses and mucopolysaccharides. What are the, even if somebody should apply common sense, kerato means cornea. Okay, kerato means cornea. So which is keratin is the only thing which is associated with cornea. Even by common sense and logic, you could have answered this question other than this. But anyways, let us see. Hyaluronic acid is present in synovial fluid, vitreous humor, and all these things. Chondroitin sulfate is cartilage. Keratin sulfate 1 and 2, cornea, cartilage, loose connective tissue. Heparin is from the mast cells, allergic and other retentions. Heparin sulfate again from skin and kidney basement membrane, glomerular basement membrane. Dermatan sulfate is skin. This you should know. Definitely everybody should know. And when it comes to mucopolysaccharidosis, everything looks like going above your head, but at least the enzyme defect you should know. Iduronate sulfatase on Hunter syndrome, iduronate sulfatase. There is no corneal opacity in Hunter. That's why he is able to see clearly, right? Sanfilippo, entire has Sanfilippo, heparin sulfate. This is a problem here. Marchio, it's keratin sulfate and chondroitin sulfate. Basically, keratin sulfate. Sanfilippo is for heparin sulfate. Marchio is for keratin sulfate. In Martiolami, it is dermatan sulfate. It's dermatan. Towards the end of the spectrum, you will get to dermatan and heparin sulfate again. So at least this much you should know. Please focus on this table again and again. They might answer. They might ask. At least focus on the enzymes, right? This question will come to the last question. This is not particularly oriented biochemistry question. I will say this is a pediatric question, but since student told me this very specifically, I have took up this question. A 3 to 4 year old boy with developmental delay, recurrent chest infection, worsening bone pain, serum PTH is normal, parathyroid is normal, phosphate is low, unresponsive to vitamin D supplementation, likely diagnosis. Right? Very classic picture. When you have something called as rickets, there are 6 types of rickets. Okay, I mean, I will keep on going to detail. So, algorithm for diagnosis of rickets is, first you should, obviously vitamin D is low, so that is there. Okay, vitamin D is low. Algorithm to treat is, first you see the PTH, whether it is high and low. Once the PTH values come, then for each one you should see phosphate. Phosphate is a blood, urine. Okay, maybe urine or blood. It's high and low. Then you should go to see something called as FGF23, fibroblastic growth factor 23, high and low. Based on each of this, you will classify the rickets as hypophosphatemic, hyperphosphatemic, phosphate, vitamin D dependent rickets, vitamin D resistant rickets, all this. Okay, in vitamin D dependent rickets, VDDR, there are type 1 and type 2. Okay, so you all know that first you have 7-dehydrocholesterol, 7-dehydrocholesterol. From there you get 1 alpha hydroxylation reaction followed by 25 alpha hydroxylation reaction. 25 alpha hydroxylase, 1 alpha hydroxylase. One happens in the liver, the second one happens in the kidney, right? If there is a defective gene encoding 1 alpha hydroxylase, then it is type 1 vitamin D resistance rickets. Okay, if you give vitamin D supplementation, in active form vitamin D you are giving, it will lead to solving this problem. Type 1 vitamin D dependent rickets is, it will solve the problem because the defect lies in the 1 alpha hydroxylase enzyme. So 1 hydroxycholecalciferol is not coming, and then second step also cannot happen because of this. Right? So vitamin D you give in active form, problem is solved. Whereas type 2 is end organ resistance. The problem lies in the vitamin D receptor. Whatever vitamin D you give also, the receptor is defective. So the receptor is defective means it cannot go and bind or it cannot exert its action. So even if you give vitamin D also, the particular disease will not respond. Simple in one sentence, the answer is done. And of course, classic features of vitamin D resistant rickettsies. Serum parathermone is normal, of course it is normal, and phosphate is low. That is because the vitamin D cannot act on the kidneys. Phosphate reabsorption is less, and phosphate reabsorption is less means phosphate is getting lost in the urine, and hence serum phosphate is low, urine phosphate is high. This is the classic picture of vitamin D supplementation. So this is the basic workup of whatever has happened in NEET 2021 Biochemistry. I hope I have done justice to all your questions, and explanations are fairly enough for you all to accept. Thank you so much for being part of this discussion, and wish you all the very best. And let me sincerely pray to God that all my students and all the students across India get the seat of their choice, and have a great and happy life. Have a wonderful day. Thank you so much. Signing off. This is Dr. A. Balasubramanian. Thank you.